Hello, this is Dr. James Welker, and I'm the Director of Advanced Medical Therapeutics at Anne Arundel Health System. Today, I have the honor of discussing the APEX trial as a guest host for this episode of the North American Thrombosis Forum's Clot Chronicles. I view the prevention of illness as the ultimate goal of healthcare. While most diseases are treated only after the patient has acquired the illness, certain illnesses give us the opportunity for prevention. Due to its association with precursor events, VTE offers this opportunity of prevention in specific patient populations. Although hospitalization is a known risk factor for VTE, nearly 75% of VTEs occur as outpatients, and nearly half of patients were in the hospital in the last 90 days. So this suggests that we need prophylaxis both for inpatients and outpatients following a recent hospitalization. For more than 2 decades, guidelines have advised for the use of anticoagulants for the prevention of VTE during hospitalization. And these guidelines recommend this both for patients undergoing surgery and those hospitalized for a medical illness. For surgical patients receiving either lower extremity joint replacement or those having certain cancer surgeries, it's recommended they continue anticoagulants for an entire month following the hospitalization. However, at this time, the guidelines recommend against post-hospitalization prophylaxis for patients hospitalized for acute medical illness. This is based on the most rigorously performed trials that include the Exclaim trial, the Adopt trial, and the Magellan trials. These trials assessed enoxaparin, apixaban, and rivaroxaban for patients with a recent hospitalization due to acute medical illness. Overall, when the data was combined to assess efficacy and safety with major bleeding events, in total, there was no overall benefit for patients. And as such, they have not been added to the guidelines. With recognition that the portion of patients suffering DVT needed concentrated to avoid unnecessary treatment of low-risk patients, and the selected treatment must have a minimal bleeding risk, the APEX trial was designed based on the foundation of data from these prior trials. Betrixaban was considered a potential candidate due to its unique pharmacokinetics that reduce the fluctuations in serum concentration and provide hope that this would translate into a reduction in bleeding events. The APEX trial included a typical hospitalized medical population. That includes patients suffering from infection, heart failure, respiratory failure, ischemic stroke, and rheumatic disease. Patients were randomized to enoxaparin for 6 to 14 days, consistent with guideline recommended course of VTE prevention. And that was compared to Betrixaban for a course of 35 to 42 days that was begun while the patient was in the hospital and continued for that duration after hospitalization as an outpatient. The primary efficacy endpoint was a composite of VT-related death, PE, and DVT, whether it was symptomatic or asymptomatic. The primary safety endpoint was major bleeding, and the patients were followed for almost 3 months following their hospitalization. What did they find? So overall, there was a reduction in the rate of VTE without an increased risk of major bleeding. And based on this data, in 2017, Betrixaban was the first anticoagulant to receive FDA approval for prophylaxis of VTE in adult hospitalized patients for acute medical illness that included data positive with a treatment that extended beyond the hospitalization. So what does this mean for the clinician? Well, for the first time, we have an option for the prevention of VTE in those patients recently hospitalized for acute medical illness. It defines the population of patients that are at sufficiently elevated risk such that they may benefit from post-hospitalization prophylaxis. It also defines a population at sufficiently low bleeding risk that they may safely receive treatment. We should keep in mind that while this is the first anticoagulant to have no increased risk of major bleeding in this clinical trial patient population, this population was selected to be low bleeding risk, and we would want to select similar patients as we choose to treat them while providing routine medical care. Overall, this represents a significant improvement in healthcare in that clinicians can now consider whether their patients whom are hospitalized for an acute medical illness are sufficiently increased risk of VTE and a sufficiently low risk of bleeding such that they may benefit from the use of petrixaban for a month after discharge from the hospital, and considering offering such patients this new option for prophylaxis. So hopefully we'll overall see future reductions in rate of VTE in society. This is Dr. James Welker signing off for the NATF Clot Chronicles.